My name is Marissa Montejano, and I'm a speech language pathology clinical fellow and long-term LEN trainee, and I'm very excited to talk about clinical services for the pediatric and feeding population. Here's the disclaimer that the information and conclusions provided in this presentation are my own. The purpose of this presentation is to provide background information about pediatric and feeding disorders, the importance of identification, the role of team members for assessment, as well as discuss the results of the study I conducted to gain insight on current pediatric feeding and swallowing assessment practices. To get started, what is a pediatric feeding disorder? A pediatric feeding disorder is defined as impaired oral intake that is not age or developmentally appropriate and is associated with medical, nutritional, feeding skill, or psychosocial dysfunction. Problems with feeding can be acute, lasting less than 3 months, or chronic, lasting more than 3 months, and can encompass a range of concerns such as oral motor difficulties, psychosocial factors, or any food selectivity of avoidance or refusal of food intake. This may or may not include problems with swallowing, which is actually described as the management and the chewing of foods or liquids, moving it back within your mouth to initiate a swallow, and the actual act of propelling that down your esophagus to your stomach. Some other examples of feeding disorders are, as I mentioned before, avoidance, refusal, or restriction of a variety or quantity of food, difficulty with self-feeding skills or using utensils, displaying any challenging mealtime behaviors, or less than optimal growth. But why is identification important? Well, approximately 25% of all children have feeding difficulties, and of those, 40 to 70% of children with chronic medical concerns, or 80% of children with developmental disabilities have difficulties feeding. Additionally, children on the spectrum are 5 times more likely to have feeding difficulties. While some can improve over time, most will persist into adulthood and have long-term effects without intervention, and may negatively affect the child's cognitive, emotional, physical, and social development. Some of these long-term consequences include food aversions, undernutrition, gastrointestinal complication, and the ongoing need for a G-tube for nutrition. Another important long-term consequence are psychosocial effects on the child's family, such as stress or anxiety and depression as they struggle to manage nutrient intake and diets. But who can assess for these difficulties? The main profession involved in evaluating for pediatric feeding and swallowing disorders is a speech language pathologist, whose role is in the prevention, screening, assessment, diagnosis, and treatment of feeding and swallowing challenges. The speech language pathology assistant's role is to demonstrate or share information with patients, families, and staff regarding feeding strategies developed and directed by the speech language pathologist. And this can be in settings such as hospitals, private practice settings, or university or college clinics. Due to the fact that more than one system can contribute to the development and persistence of pediatric feeding disorders, assessment of all contributing factors is important for yielding optimal care and quality treatment plans. Thus, multi or interdisciplinary teams are important for evaluating feeding difficulties, including a speech pathologist, as mentioned before, to assess for any feeding skills or swallowing function, a dietitian to assess for growth and nutrition, a medical doctor to assess for any of those underlying medical causes, an occupational therapist to assess for any sensory processing or fine motor skills involved with feeding, and a psychologist or behavioral therapist to assess for any of those contributing behavioral components or psychosocial stressors that I mentioned before. Knowing all of this information, as someone with an interest in serving this population, my research question was, what are the gold standard clinical guidelines for feeding evaluations, including what's the clinic structure like? Are there any screening measures or standardized assessment protocols for assessing for feeding? What teams, are there teams being used, such as multidisciplinary, interdisciplinary? And if so, who are the main assessors? To see if this question was already been answered, I performed a preliminary search using the term feeding clinic on the American Speech and Hearing Association Swallowing Disorders listserv. And out of about 100 posts, only 5 were about developing feeding clinics or the roles of interdisciplinary team members, and they received little to no responses. Additionally, a literature review of about 33 articles found little in terms of assessment, with most studies focused on descriptions of mealtime behaviors or treatment, highlighting that gap in the literature and the need for more research into this question. For this study, I interviewed 5 providers who specialize in feeding and swallowing disorders. The providers were given the same set of 15 open-ended interview questions. All questions were provided in advance, and data were collected through written responses or transcribed live during the interview. And then all interviews were analyzed to find themes. Participants included 4 speech-language pathologists and 1 developmental and behavior pediatrician. They all had around 10 to 30 years of experience, and their settings included outpatient hospital clinics, inpatient hospital, private practice, and 1 provider who had experience in inpatient and outpatient, but then switched to early intervention in schools for feeding and swallowing. 3 were currently practicing, and 2 were retired within the last 1 to 3 years. Their client population that they served included ages birth to early 20s, but mostly birth to 5. Diagnoses included respiratory issues such as trach or ventilated, GI issues such as G-tube dependent or failure to thrive, other medical issues such as prematurity, cardiac, seizure disorders, or organ transplantation, and then neurodevelopmental disorders such as autism spectrum disorder, cerebral palsy, intellectual disability, Down syndrome, and fetal alcohol syndrome. Now let's discuss the results. First, regarding assessment of feeding and swallowing. While all participants had common processes of how they assessed, including record reviews, clinical interviews, observation of feeding skills, and swallow studies when necessary to observe the swallow function, if that was available to them, when it came to formal or standardized feeding assessment protocols or measures for assessing or screening, all respondents stated that there were none that were used. Instead, every provider cited different research that they used to assess, which varied by setting. Reason for not using any existing measures were that there weren't very many that were actually truly validated, or the ones that existed just weren't psychometrically sound, really highlighting that clinicians value well-developed measures. In terms of clinic structure, for assessment of feeding, all respondents identified that they were either currently or had been on a feeding or interdisciplinary or multidisciplinary team. When analyzing the data further, the team varied depending on the setting. However, as you can see here, 1 constant team member was a speech-language pathologist. And to further highlight this, in an early intervention or school setting, the speech-language pathologist was the only member of the team, as in they assessed, treated, or provided consultation independently. Additionally, the speech-language pathologist was mentioned as being the main assessor for all swallowing, feeding, and oral or motor-related skills assessments. Though others were mentioned as well, such as a registered dietitian for nutrition and a medical exam by doctors and nurse practitioners. To further look at clinic structure, 4 to 5 respondents highlighted that being part of a multi or interdisciplinary team was a strength of their feeding program. Some reasons that they provided was that quick access to team members and the ability to have consistent consultation and coordination led to quicker time creating a plan and a more quality plan for their patients. In addition to my original research question, I also found added interesting information when it came to challenges of feeding programs. 3 to 5 highlighted the lack of trained SLPs in the feeding and swallowing specialty and the need for more local providers to fill roles. Additionally, another provider discussed difficulty coaching parents' feeding strategies upon discharge out of the hospital, citing lack of resources and time as a reason. And another highlighted the lack of standardization measures was also really difficult for families, highlighting that families also valued these validated measures. In conclusion, feeding disorders have a high prevalence in children who are medically complex or with neurodevelopmental disabilities. Without intervention, these disorders can persist into adulthood and cause long-term effects, highlighting the importance of screening, identification, and quality assessment for the creation of treatment plans. For this study, no standardized formal screeners or assessment protocols for feeding difficulties were identified. While providers mentioned existence of some measures, their lack of validation or psychometrics was cited as the reason for non-use. The lack of standardization was also a challenge for families. Outside of SLPs, medical professionals such as pediatricians or other providers who frequently see children are an important resource and can be the first to screen for pediatric feeding disorders and make appropriate referrals if necessary. Therefore, more development and research into standardized screeners would be beneficial to this population, their families, and providers. Additionally, multi and interdisciplinary teams were considered an asset to a feeding program, which was confirmed through this study. This makes sense given that feeding disorders are influenced by different systems and the plans of care change dependent on these factors. Therefore, in line with the literature, having access to collaborate with other specialties will greatly increase the quality of care for clients with pediatric feeding disorders. In addition to that, SLPs are highly specialized in the anatomy of oral motor and swallowing function. And it was also confirmed in this study that they play a crucial role in the feeding assessment team. However, there is a lack of enough trained SLPs in the assessment and treatment of feeding disorders. And because SLPs are a key member of the pediatric feeding team and are in such short supply, SLPs can be an essential partner out to the feeding team and a helpful solution to helping families transition from clinic to in-home by reinforcing the SLP's treatment plan under their supervision. Additionally, collaboration between these two can help them each work at the top of their license, meaning that the SLP has more time to assess with medically complex children, and the SLPA can then assist and reinforce that plan as needed. Some limitations to this study is that there was a small sample size and a less variety of providers, and interviews relied on the examiner's live transcription skills. Some strengths of this study were participants had many years of experience and were in a variety of clinical settings. A future direction would be to continue the study focusing on other areas of California, as this mostly focused on the greater Sacramento area, or a broader study looking at clinical services nationwide, and a look at existing screening tools. I'd like to acknowledge all the participants in the study, for which I would not be able to do this without my clinical supervisor and research mentor, Heather Thompson, for helping guide through this project, as well as my other clinical supervisor, Nancy Castanetti, for always helping me critically think, and the UC Davis Mind Institute and LEND program.
I have a question for you. I was happy to see that PTs actually showed up somewhere on the list of the reported team members. Would you tell us what the PTs did, or do you know what their role was in the feeding assessment?
So I actually only mentioned occupational therapists. So I didn't actually see any that were with physical therapists in general, but I know for occupational therapists, a lot of the times they work on the posture or their sensory aspects of it. And so I apologize if it said PT in there.
Actually, I think that it wasn't on your slide. It was on the results from the interviews that people
gotcha.
reported that PTs were.
Yeah. Oh, yeah. So that was, I know exactly what you're talking about now. Yes, that was for the private practice team. The PT is involved, but actually she didn't provide any specifics on what they do. She just told me the team members. So the only specifics she gave were what the SLP does within the role and then what the OT does. So that actually would be a good follow-up question and a way to elevate the study even further, because I didn't ask what the PT does. So I apologize.
Usually it has to do with seating and supporting the posture of the child, especially in those children that have neuromuscular conditions where there's really not a lot of support in the trunk. So it's nice to see that we showed up there somewhere as PTs. I've certainly been in feeding clinics with in that role with children, mostly with cerebral palsy, and it's really important. Everybody should remember that if your posture is not good, you can't swallow. So
yes, absolutely, 100%.
Thank you, Marissa. It was really interesting.
In the chat, Mary Beth was saying that sometimes the OT does consider themselves the primary therapist, so interviewing them might be a nice next step. And then Jean's recommendation that teachers for those school-age kids would be involved as well. Any other final questions for Marissa?
Yes, this is Len. Great presentation. I really appreciated that. So given the frequency of feeding problems, why don't we have measures? Do you have any sense as to what is holding us back? And kind of related, and maybe this is will sound like a mean question, and I don't mean it to be, but
no,
sometimes we look at kind of people that are in the field a long time and we assume that they have the most current knowledge. That may not always be true. And I wonder if, and Heather would be able to answer this, and Marissa, you could find whether if you interviewed people that are newer into the field, would they have a different view, a different approach to their role and measures in feeding clinics? So there's a lot there. So answer whatever you want.
No, Len, I love that you asked this question, because I was actually, when I started this, I was thinking, I'm going to find a whole bunch of great measures, most likely. And then I was so disappointed to find that I couldn't find any, at least in this small sample size. And I know that maybe if I had more, obviously more, that was a limitation. If I had more providers or more with a varied experience, it was possible to identify those. I think it also would have been elevated if I had followed up the question on what screening measures they actually had heard of, because some of them were like, I've heard of them, but we don't use them, but didn't name what they were. And so I think this is a really well needed area for more research on more screeners. If there are those that are existing, why are they not getting into the hands of of our clinicians to be using them? That would be another good question, because there might be some out there, but maybe why is it not going forth into the community?
I can kind of speak to this from a perspective of teaching in higher education. What does our graduate cohort look like in terms of their interest? We have in every given year about 35, at least at Sac State, like 35 grad students in speech language pathology. And there are so many areas of specialty that one can focus on in speech language pathology. And we work across the lifespan from infancy through to the geriatric years. And so if you have 35 students, and even if they're all interested in something completely different, we might have maybe 1 or 2 interested in feeding. And then there's a lot that go to the adult hospital-based internships and then stay in the hospitals to work with individuals after they've had a head injury or a stroke or a cardiovascular incident or a gunshot wound. And so just in terms of where people are landing through their educational training, there's a shortage of practitioners who are very interested in working in pediatric feeding exclusively. And so then what do you get in terms of internships? So if you have only a handful of SLPs who are working in the area, they're not training future generations. And so that's why we really value those SLPs who are working in pediatric feeding and also interested in taking interns. So I can just speak to it from a logistical barrier. So we need more people like Marissa. Thank you, Marissa.
Thank you, Heather.
Research, and then to take on, and maybe she'll take an intern in the future and mentor future colleagues and, support that next generation. But congratulations, Marissa. Great job. And great job to all the speakers today.